Hello and welcome to this lesson, anal fissure. Anal fissure is one of the most common causes of rectal pain, and in this video we are going to talk about everything that you need about anal fissure for your board examination. So first, let's understand what is anal fissure. Anal fissure is defined as a tear in the anoderm. So if you look at the anatomy of anal canal, you are seeing that we have inner lining, which is called anoderm. This is where we have tear, which is surrounded by the internal and external sphinctering muscle. And these external and internal sphinctering muscle are surrounded by the fatty tissue. So in case of anal fissure, we are going to tear in the posterior midline of anal canal in the anoderm part, but also patients can have tear in the anterior midline, but this is less common than posterior midline. Another point is that usually this group of patients who are suffering from anal fissure are chronically constipated, but they can also have prolonged diarrhea and develop anal fissure. So this tear is going to cause pain and a spasm of internal sphinctering muscle, which causes a vicious cycle. So the vicious cycle is the fact that due to the spasm of internal sphinctering muscle, we are going to have increase in resting tone of muscles of a sphincter, internal sphinctering muscles. This increase in resting pressure of internal sphinctering muscles causes decrease in blood flow in the anterior and posterior midline, and this decrease in blood flow causes delay in healing process of the anal fissure. So the presentation will be sharp pain, and this sharp pain is usually during or immediately after bowel movement. Most of the patients who are suffering from anal fissure have chronic constipation, so the compacted fecal content can cause tearing of the anoderm and cause hematochezia. Also, again, due to the fact that the patients are chronically constipated, they may have hemorrhoid. Also, we can have rectal bleeding and sentinel tag in case of anal fissure. And the pain is described as a stabbing pain, and due to this pain, it is very difficult to perform digital rectal examination of anal canal, either with the finger or with anoscopy. So these are devices that we are going to use. Usually we are using anoscope, which is this device, and we use this device for the anoscopy of patients who are suffering from anal fissure. So another point about anal fissure is that we can have two types of anal fissure. We can have acute anal fissure, which is due to superficial tear of the distal anoderm, and this is usually treatable with medical therapy, and this responds to therapy very well. We can also have chronic anal fissure, and this is due to ulceration of anal fissure, which is usually presented with healed edges, and a skin tag can also be seen in this group of patients, and also hypertrophy of internal anal papilla is also possible, which is an indication for the surgery. So this is a sentinel skin tag which is seen in chronic anal fissure. Also, if you note, this is a normal anal papilla, and in case of chronic anal fissure we can have hypertrophied anal papilla, which is an indication for the surgery. So what are the differentials for anal fissure? Note that we can have other diseases that can cause ulceration and anal fissure. For example, we can have inflammatory bowel diseases like Crohn's disease or ulcerative colitis, and this is due to the fact that these two diseases can cause prolonged diarrhea, and as the result the patient might develop chronic anal fissure. Another etiology is leukemia, and infection can also cause anal fissure. So when to suspect we have, for example, leukemia or infection or Crohn's disease and ulcerative colitis as the cause of anal fissure and ulceration. Probably the most important differential point in the differential is the location of the tear. As you remember from previous slides, most of the patients who are suffering from anal fissure are going to have fissure in the anterior midline or in the posterior midline. The lateral location of the ulceration is a great hint for the further examination. Another point is that in case of anal fissure, we are going to have increase in a sphinctering muscle tone. So if you have decreasing tone of a sphinctering muscle, this is a great indication for having further examination. So the patient should have biopsy of that part in order to rule out infection or other malignancies. So what can be the complication of anal fissure? Of course, bleeding from fissure site is possible, pain, which is the most common complaint of of this group of patients, and also infection of the fissure is possible in case of anal fissure. But probably the most feared complication is fissure fistula complex formation, and this is when we have a fistula which is connected to the part that we have anal fissure, and these patients have a great chance of developing, for example, infection in case of anal fissure. So we have very different forms of fistula. We are going to describe them in another video. We can have submucosal fistula, intersphincteric fistula, transsphincteric, suprasphincteric, and extrasphincteric fistula. All of them are quite possible in case of anal fissure, but we are not going to discuss it in this video. So what are the treatment options in case of anal fissure? First of all, what is the goal of treatment? The goal of treatment is to break pain, because pain is causing great discomfort for this group of patients, and also to break a spasm of internal sphincteric muscles, because without relaxation of the muscles we are going to have delayed healing, so this causes further complicating the situation. So the first option which should be prescribed for every patient is a stool softener and laxative, because we are not going to cause further trauma to the patients. The warm seat path is quite effective because it helps relaxation of internal sphincteric muscles, and also we have other muscle relaxants. For example, we have topical nitric oxide and calcium channel blockers. Both of these two agents are causing muscle relaxation, so we can use them as a topical agent in order to have relaxation of internal sphincteric muscle. But in case of nitric oxide, the patient may experience headache, and this might be hard to tolerate for few groups of patients. Newer options are arginine. Arginine is a nitric oxide donor and can cause relaxation of internal sphincteric muscle, and also bethimecol, which is a muscarinic agonist, can be prescribed for this group of patients. So if topical ointment fail to decrease the pressure of internal sphincteric muscle, the patient is a candidate for the surgery. And the surgery that is done is a sphincterotomy, and it can be complicated with bleeding, infection, and it can rarely cause fecal incontinence. But mostly medical treatment is going to be effective, and most of these patients are not going to require any type of surgery. So thank you for watching, and see you in the next video.